Dear participants, I wish to welcome you all to this webinar hosted by European Federation of Clinical Chemistry and Laboratory Medicine, and particularly by Working Group for Distance Education, represented here by Chair of Working Group Distance Education and the e-learning Daniel Reidel and the Young Scientist member Adaite. My name is Zorica. I am corresponding member of EFLM Working Group Pre-Analytic Phase, and it is my great pleasure to announce our today's speaker, Stephen Church, who joined Becton and Dickinson in 1990, and he has played an active role in design, development, and implementation of medical devices for over 25 years. Initially working as a member of BD R&D team, Stephen has conducted more than 40 evaluations of BD products at hospitals and laboratories in Western Europe. For the past 14 years, Stephen has been working as a clinical specialist supporting the implementation of BD blood collection products at the hospitals. In this role, Stephen has been able to support hospitals by working together to make significant improvements in their processes and the practices. Stephen is a member of a number of working groups including ISO, EFLM, and IFCC. He has published a number of articles and made presentations at scientific meetings on various topics, with key topic being laboratory medicine. Recently, Stephen has moved to the role of the Clinical Director, BD Medication Delivery Solutions, and so he has unique insight into both the needs of laboratory medicine and IV access. As an expert on EFLM Working Group Pre-Analytic Phase, Stephen has given great contribution to work of this working group, and also in that way improved the field of pre-analytics with his huge experience. As you have seen by topic of webinar, today Stephen will talk us about a very important issue of collecting blood samples for vascular access devices, procedure which is mostly used in emergency departments or intensive care units, and which, if not implemented in a proper way, can often lead to obtaining low-quality specimens and threatens with obtaining incorrect results and compromising patient safety. This webinar will overview all the risks associated with the blood collection from vascular access devices, the type of them, and also will provide recommendations on the best practices to obtain the highest quality sample and ensure patient care. At the beginning of this webinar, I would like to inform you that this webinar will be interactive, and we will ask you some questions during the webinar, and you have to answer within 15 to 20 seconds, so please be concentrated. The similar questions will be in the quiz after webinar. Also, I would like to inform you that you can type the questions during the webinar in the chat window, and we will discuss about these questions after webinar. I know that we will enjoy today's presentation and we will learn a lot from it. So, Stephen, the microphone is yours.
Thank you very much indeed, Zorica, and thanks for that great introduction. It is indeed my great pleasure to present this webinar on behalf of the EFLM working group on the pre-analytical phase. And as Zorica says, with my experience within the field of laboratory medicine, together with my more recent role working in the BD-IV catheter business, I have a good understanding of the two, and already understand some of the complications that may arise. So today's webinar objectives really are to give you an overview of why IV therapy is used, and for those of you not familiar with the different types of vascular access devices, to explain some of the different devices, to consider what are some of the current guidelines that are available to us today. But I'd also like us to think about why nurses and why people would collect from a vascular access device. So give us that nursing perspective. And of course, think about what it means for the laboratory. and then perhaps go a little bit deeper on some key considerations that arise from this practice, and finally with some recommendations. And as Zorica said, throughout the webinar there will be some questions available for us, so please join in and vote and give us your opinions as we go through. Just a couple of clarifications. First of all, we're using the terms catheter. Sometimes you hear the term catheter or cannula or cannulation. We're using this whole terminology to really think about vascular access devices and their implementation. So if you're familiar with those terms, they equally apply here. The focus of the webinar is on intravenous catheters, so we won't be discussing other types of catheters such as urinary catheters.
So question number 1. Do you currently have specific protocol for collecting blood samples from vascular access devices? Yes, no, unknown. Please select answer in the voting window on your screen.
Okay, let's take a look at the results that we have now. So hopefully you can all see the votes on the screen, and it's very interesting that in fact nearly over 50% of you attending already have a specific protocol for collecting samples from vascular access devices, which I think is truly excellent. In fact, in my experience, it's not usually that high when I visited hospitals and asked these questions. They don't have a specific protocol for vascular access devices, but they do have one for blood collection in general. So hopefully as we work through today, we can convert the rest of you into generating a protocol for vascular access device collection. So why intravenous therapy? So this is a good question. Why is this going on? It's usually done to restore and maintain the fluid and electrolyte balance within our blood systems, within our vascular systems, and it's the route by which we administer many different types of medications, particularly antibiotics, drugs for pain management, for chemotherapy. So there's a significant opportunity or significant way of administering medications. It can also be used to help in the delivery of parenteral nutrition. So when people are unable to eat, this is the way in which nutrition is delivered. And of course, it can be used to administer blood transfusion and blood products. But why particularly through the vascular access system? Really because of its direct route into the bloodstream. You're clearly applying these types of medications where they will be rapidly absorbed into the human body. It enables us to give very accurate and precise drug administration, and we have a good understanding of of how the drug will act. There are some things that you can't deliver via other routes, such as total parenteral nutrition, because they are irritant, and so this is the only way that they can be delivered. And sometimes there are elements that cannot be absorbed by any other way. So there's a very good reason why we would deliver treatments and things through vascular access.
Question number 2. What percent of hospitalized patients have catheter vascular access device? From 0 to 10%, from 10 to 20%, from 20 to 50%, from 60 to 90%, more than 90%, 90% plus. Please vote.
Okay, I think we can show the results again. And it's very interesting to see that that we are split across the different different voting. But typically it's around 60 to 90%. So a high proportion, and again, correctly, as many of you identified, a high proportion are of hospitalized patients do have a catheter or vascular access device for their treatment whilst they're in hospital. So we know that it's something which is given to many patients, and we need to think about how do we collect samples from these types of device. So central intravenous therapy has played an important role in patient care for many hundreds of years. And as we've already seen, many patients receive this therapy, and yet it's also one of the potentially most common but yet complex procedures that goes on with a different array of devices and a different way of connecting for different types of patients. So we really have to think about how do we make this procedure such that we can then allow blood collection, or think about how we would do blood collection through these different types of devices. So the types of vascular devices. So I'm going to give some very brief outlines of these different types of devices that may be used. The first device that we should think about is what we would call a peripheral device, where the catheter tip is usually placed in the forearm or in the back of the hands in the syphilic veins. Then there is another peripheral device, often called a midline or a mini catheter. Usually this is inserted in the forearm and its catheter tip runs to the top or to the superior vena cava. Then we have a central venous access device, where this is a much longer device, and the tip of this one actually ends up in the top of the superior vena cava. And then finally we have arterial devices, where the catheter tip is usually placed in the radial artery, but of course there are other arterial accesses that could be used. So we have these different devices: peripheral, central, and venous. I will generally today focus on the peripheral and the central venous, but some of these, generally collections from arterial devices is not recommended. So let's take a look now at some vascular access devices.
Question number 3. Which of this is not a vascular access device? Peripherally inserted venous cannula, central venous catheter, urethral catheter, peripherally inserted central catheter, midline catheter. Please click on the answer.
I think we can publish the result of this poll, and I'm very pleased to know that nobody was at all fooled by this question, and everybody realized that the urethral catheter is clearly not a peripheral, a vascular access device. So great. Okay, let's move on. So when we look at these different types of devices, first we talked about the peripherally inserted venous cannulas. As I said, these are usually in the forearm or in the back of the hand. They're usually short in length, typically between 14 and 75 millimeters, and these are often used for blood collection. So you'll see these devices used a lot, especially in emergency departments and those types of areas. Another type of peripheral device is called a midline catheter. This is inserted into the upper arm. Again, it has a single lumen that's connected through into the brachial vein. Typically, these can be from 75 to 200 millimeters long, so they're quite long. compared to the other peripheral devices, and they're typically inserted for 1 to 4 weeks. So they will be in place in the patient for a much longer period of time. If we think about peripherally inserted central catheters, so these are the ones that run to the top near the heart. These can be much longer in length. They can have multiple lumens, so you can deliver different types of therapy through each of the lumens. They can be in place for potentially up to a year. And there are different types of these devices depending upon the type of medication you want to deliver. So these are, again, a very different set of vascular access devices. Then there are long-term central venous catheters. These can come through the jugular, they can come through the subclavian, they may be tunneled, they may not be tunneled. So there's a whole range of these types of devices. Typically they have a very long dwell time, and often these are used in critically ill patients. And then finally, as we talk about these different types of vascular access devices, there are vascular access ports or implantable ports. So these actually sit underneath the skin. And to connect to these, you need an external needle, such as a Huber needle or something of that nature, that enables you to connect into the port when required. And these ports can actually be in place for several years, so they could be in place for a very long period of time. So hopefully that gives you some brief idea of the different types of vascular access devices that there are, and how those devices are very different in terms of their size, their length of their dwell, and also their potential uses. So are there any guidelines for us with regard to collecting from these types of vascular access devices? So let's look at one that most of us will be familiar with, the Clinical Laboratory Standards Institute from the US, a global group. They, in their most recent guideline around blood collection, that's version GP41A7, they say avoid collecting through a vascular access device or during an IV start. So clearly they're indicating that there's a concern here. However, they do go on later in the standard to give some guidance about how to collect when from a vascular access device or when infusions are ongoing. So there's a little bit of a confusion there, I would say, but their overall recommendation is to avoid the collection. If we now look at some nursing guidelines rather than laboratory guidelines, this is the UK Royal College of Nursing. They have a guideline for infusion therapy, recently published, 2016. And you'll see here that they say peripheral cannulae should not be routinely used for blood sampling because of the potential quality issues. And they suggest that samples can be taken at initial placement. So a little bit different from before when we talk about IV starts and what might be going on. But again, think about how you use them. And again, they do give some guidance that we'll talk about a little bit more about particular processes for blood sampling. If we look at the Infusion Nursing Society, this is a major group. They also produced a therapy standard, infusion therapy standard in 2016. And they say, when sampling via a vascular access device, carefully analyze the risks versus the benefits before deciding to use a vascular access device. So clearly there's a word of caution there for people to think about, should this be the right way to collect my sample? And again, they do, however, go on to provide some guidance on how to potentially collect from those samples. So all of those guidelines I will bring in as we continue through here, some of the recommendations that they make. What about other guidelines? So if we consider the WHO guidelines on drawing blood, They provide no guidance. And even our own recently published EFLM guidelines on recommendation for venous blood sampling, we recognize that this is a different area and that we need to address this via a separate approach, which is one of the very reasons for today's webinar, to start raising the awareness and having the discussion around how do we collect from these different types of devices.
So now we have question number 4. Based on survey of nurses, what are some of the reasons for collecting blood through vascular access device? Please select all that apply. To reduce the number of skin punctures, to reduce the pain and discomfort for a patient, reduce cost, standard policy for patients admitted to emergency, and convenience.
Okay, thank you very much. Maybe we can show those results now. Can you make the results a bit bigger so we can see them on the screen, please? Thank you. So I think that's very interesting. We now got a much more mixed reason for why people may want to, or why nurses collect from a vascular access device. There's definitely a consideration around the care for the patient, so the number of punctures and the discomfort. We also see routinely that it's almost a standard practice when somebody comes into an emergency ward, they are catheterized and bloods are collected in that way. It's often seen as being a very convenient way. I've already managed to get venous access in potentially what was a difficult patient, so it's an easier way to do it. I don't actually think that many have responded that it is around reducing cost. Of course, it could potentially be, but I think in reality, it's probably more associated with those other areas that we talked about. So reducing the number of skin punctures, reducing pain, being a standard policy, and being a very convenient way to access. Okay, if we can move on. So let's think more about that nursing perspective. This idea, the nurses are clearly working to make their best efforts of how to collect a blood sample, yet there are some reasons of convenience that we talked about and some patient areas why they may have focused on collecting from the different type of samples. And I think maybe one that's not there is that they may not be aware of the potential issues of collecting through a vascular access device. So let's see some further data based upon this survey that was conducted. So 43% of vascular access devices have had blood collection from them. And in fact, if we take it to the emergency departments or a specific part of the hospital, that can be even higher, as high as 90%. So a high proportion of vascular access devices do have blood collections. And in fact, also the nurses reported that these devices may well be accessed up to 16 times a day in some units. So they're there, they're very easy to access, and they're very quick, often accessed. 43% of them, however, are not aware of any issues of collecting through a vascular access device. And those that are aware describe the results as being primarily, the impact as being primarily infection, contamination, and poor results. So I think we know that some of those are correct, but others may not be. Finally, when asked how many times what percentage have had to retake blood samples, some 78% of the respondents said that they had to retake samples due to quality issues. And on average, there are quality issues with 13% of the samples that these nurses were taken from vascular access device. So I think those last two really shape the thought. However, I'm being asked to retake, and I'm seeing particular quality issues. So it begs the question, you know, what's the best way to do it? And even should I be collecting from a vascular access device? So let's look a little bit from the laboratory perspective here. Many of you will be familiar with these. Maybe some people will be less familiar, but typically the potential interferences that we see from collecting via a vascular access device are hemolysis, contamination of the blood cultures, contamination of the blood sample with IV fluids, and often it's recorded impact upon clotting results. So let's have a look at those in a little bit more detail. So hemolysis. This is an extract from a publication in 2009 where they looked at a number of studies where they had looked at hemolysis as a result of hemolysis through collecting through different types of vascular access device. And it may not be clear to you on the screen, but in some of the studies that they reference here, there is a dramatic difference in the rate of hemolysis between the IV catheters and the conventional venipuncture. For example, this study here, 21% of the IV catheters had hemolysis versus 0% for venipuncture. If we look at this study here, 13% for the IV, 3.8% for venipuncture. So there's clearly a lot of evidence suggesting that there's a great deal of difference in the rates of hemolysis between samples collected from a vascular access device and that of direct venipuncture. Further, more recently, Professor Lippi and Professor Plebani and the group in Italy have done a critical review of hemolysis in the emergency department and the potential causes. And again, they have identified that new catheters, the placement of the catheters, the difficulty in collecting blood, and multiple attempts to place catheters are really some of the reasons that are creating significant issues for hemolysis. So collecting from IV catheters does pose an issue from hemolysis, for hemolysis.
Now we have a question number 5. Which of these are potential causes of the hemolysis when vascular access device is used for collecting blood? Select all that apply. Collection from newly inserted catheter without scar tube, lifting a catheter hub, kinking of the catheter tubing, tortuous path, vein collapse during collection, and incorrect order of draw. Inappropriate transfer of sample from syringe to blood collection tube.
Okay, please publish the results. And if you could put it more in the middle of the screen so I can see the results. Great, thank you very much. It's spread across the results. I think there's clearly evidence that supports around the trauma that's created through a newly inserted catheter and not using a discard tube. Lifting of the catheter hub and kinking of the tubing during collection is a clear case. And in fact, very recently, I was in an emergency department and I saw them make a collection, use a catheter. They didn't stabilize the catheter, and they were lifting the catheter up and connecting the sample to the blood collection device, to the vascular access device, and the patient was clearly getting a hematoma, and lo and behold, when I asked later, the sample was hemolyzed. So, you know, this tortuous path, this difficulty in the collection is important. Veins collapsing can have the potential, as they always do, to hemolysis. I don't believe there's any data that supports incorrect order of draw itself creates hemolysis, and certainly inappropriate transfer from the blood, from a syringe to a blood collection tube, is another area. So there are 4 good reasons there, or 4 potential areas where we can create issues when collecting from a vascular access device. Okay, let's move forward. So I talked a little bit about blood culture. Why might that be a concern? Well, one of the things that we know is that a catheter is a particular venous access device that is, of course, completely open to our venous system. And so we have to take care and we have to clean it. And we also know from our literature that it's one of the key areas in which infections can happen in the hospital. So we know that there are catheter-related bloodstream infections. So being careful about the catheters is very much important. There are a number of guidelines that talk about this, but certainly if we look at the CLSI one, it clearly indicates that blood cultures from indwelling vascular access devices are associated with greater contamination rates. And that's kind of aligned with what we were showing on the left-hand side here, that yes, there are more contaminations through catheter-related devices. And you can also see the little snapshot of a number of the studies which again demonstrate that blood cultures from central catheters and other types of catheters have a significant impact on those correct results. Our overall recommendation here is to not collect blood cultures for a vascular access device. I think it goes without saying, because of these potential issues, because of the ongoing potential contamination of the vascular access device itself, it doesn't make sense to collect blood cultures through a vascular access device. If we think about IV fluids, by this I mean intravenous fluids. Intravenous fluids are generally used to deliver water, electrolytes, glucose, vitamins, proteins. They may be delivering nutrition. So there are very specific elements that are being delivered through these IV infusions. And some of the most common IV fluids that you might see are normal saline, dextrose in water, lactate ringers or lactate solution, which is not only contains lactate, but it contains sodium chloride, potassium chloride, calcium, and many other things in sterile water. So I think what we can clearly see here, as from a laboratory point of view, there are many things that we want to measure the true concentration in somebody's blood that are delivered by these IV infusions. So we need to be careful. You know, if we measure something from the IV fluid, we will get a erroneous or elevated result, unrequired, not necessarily. So how does this happen? If you draw from lines with ongoing infusions, if you draw from lines which have not been flushed, so in other words, they may have flushed a line, but they haven't drawn out the volume, so you've still got a contaminated sample. Or you may do a vena punch directly above the site of the infusion. All of these areas leads to us having potentially contaminated samples. And we may recognize these sometimes when we see them in our laboratory, because the samples often look very diluted as well. So what are our recommendations? So clearly the recommendations is, if you're going to collect from a sample which has an IV going on, then you need to stop the infusion and discard an appropriate amount of volume of blood. So I'll talk in a little bit about how much and for how long do we need to do that. If we think about our clotting results, many studies show that you can collect your routine coagulation parameters from peripheral devices. So these are the ones that we mentioned were usually in the lower forearm or the back of the hand. These peripheral devices, many studies show no difference between the results collected through venipuncture and through these devices, providing a discard tube has been used. However, if you look at central vascular access devices, so these were the longer devices, often associated with more continuous therapies. They may well be using citrate or heparin lock solutions. In those types of scenarios, some studies have really shown that there is, even if you take quite a significant volume of blood, it's not possible to eliminate the influence of the IV solution or the lock solution and get appropriate coagulation parameters. So we really have to be careful when we're thinking about the different types of device and where we're collecting from. So again, this will be something that we need to build into your protocol to make sure that you know when you can collect for coagulation results. So when should you collect from a vascular access device? You know, if you're a nurse, you've heard most of what we said. Okay, when can I do it, or when should I do it? Well, I think, as we've already said, a number of the different guidelines give a slightly mixed view, but I think the overriding element is you need to consider the needs of the patient, and you need to consider the potential inconvenience or pain that may come up through blood collection versus the potential impact of erroneous results. So there's, you know, you need to be thinking about that as a nurse. And so it's quite an open answer, but I think it's really, you know, you have to decide when it's clinically necessary. When is this really the best and optimal way to do it for the particular patient? And I suggest that we don't have that thought process that often, and in fact that we routinely collect through these devices rather than thinking, is this truly clinically necessary, or is it better for me to collect via venipuncture? What about if I have an ongoing infusion? So now there's an infusion running through the patient, and as we've already discussed, the potentials for collecting from an infusion such as sample dilution or erroneous results are quite significant, so we need to think about those. And we need to think about stopping the IV for a period of time. So the INS, suggests that when collecting from a peripheral device, you should stop it for at least 2 minutes prior to obtaining the blood sample. However, for central devices, there is really not a defined length of time, and some studies have suggested that even you know, you may have to wait up to 10 minutes when you're looking at a central line. So clearly there's not a one size fits all for the different types of peripheral device. But again, you need to know which peripheral device am I collecting from. You know, that is an important consideration. So our recommendation would be that you should stop all infusions. You should wait a minimum of 2 minutes, perhaps longer, depending upon the type of infusion and its location. You should flush the lumen with saline before collection. So not heparin, not citrate, flush with saline, and calculate how much discard do I need to take, how much volume of blood do I need to throw away. And that in itself is a difficult question. You know, how much do I need to calculate to throw away, or can I calculate it? So just to give some definitions for everybody, when I'm talking about discard, I'm talking about the volume of blood that you should collect into your blood collection system, which is not used for analysis, which is disposed of. And when I talk about dead space, I'm talking about the internal volume of the vascular access device. So clearly, if you can calculate the internal volume or have some idea of it, you can then start to think about how much to to discard. So let's look at these two different devices. One peripheral device has an internal volume of about 0.2 milliliters, whereas a central line PIC in this case has 2 ml. So, considerably different internal volumes. And also need to remember that that's not the end of these devices. They are connected to usually some kind of set of some kind. So it could be just a single connector like this, or it could even be, a quadruple collector. So you may have, again, a very different volume, and you need to consider not only the volume of your catheter, but the volume of your connections as well. So how much blood should I discard? Well, many manufacturers do make devices and tubes specifically to give you 4 discards, and they are available from a number of companies. But the CLSI suggests that in general, you need to do 2 times the dead space, unless it's coagulation, in which it's 5 ml or 6 times the dead space. So what tests am I doing will determine how much I need to discard. The Infusion Nursing Society suggests that when you're looking at central vascular access devices, it really depends upon the type of vascular access device. So there's not a clear understanding of what it should be. So some type of recommendation is, clearly you need to understand what type of vascular access device is being used. You need to know what it is. You need to think about the volume of the vascular access device and any connections, and then calculate the appropriate volume. But I think as a guide, peripherally, 2 mLs, unless it's a coagulation, 5 mLs. For central, at least 5 mLs, if not more. So that gives us some ideas of the amount of volume to discard. I do think there's more studies are required, more data is required to get to a firm conclusion on that. How should I connect to this vascular access device is also a key question, because connecting incorrectly has been shown to have an impact. So if we can connect correctly, we will have ability to reduce hemolysis. And basically what we're trying to do here is to reduce the mechanically induced shear stress that's on the red blood cells. So as you can kind of see in this diagram here, we're trying to demonstrate that the blood goes through lots of different things and potentially may be impacted. So one of the key things is to make sure that you use a holder so that you have an appropriately connected device that securely fits into your connections. There are indeed, very recently, many of you will have seen the PIVO device that's been mentioned as a way of further reducing that stress and enabling connection to catheters. We have seen many studies that look at what we might call a controlled aspiration technique. And we've also seen studies that talk about these tubes that have a differential draw volume, what we might call partial draw blood collection tubes. If we look at the literature, there's a lot of literature around this area. This first article appraised the incidence of hemolysis through a whole series of different factors, and certainly concluded that large, big draw volume tubes would influence hemolysis. More recently, from Professor Lippi, he's looked at hemolysis drawn by different between standard blood draw and intravenous catheters, and demonstrated there is a difference, and further said that when primary evacuated tubes may be associated with higher hemolysis than manual aspiration. However, conversely, recently other people have looked into this difference between the different types of collection technique. This one here demonstrates that not only does it provide a calculator for calculating the potential impact on hemolysis, but demonstrates that the use of partial draw vacuum tubes gives an equivalent performance to that of careful aspiration. And again, another study here looking at the influence of using partial draws, and hopefully everybody can see here that after the introduction of the partial draw tubes, there was a significant reduction in this hospital in Italy in the level of hemolysis. So how to connect and how to draw is an important aspect when we think about collection from blood vascular access devices. Finally, if you collect using a syringe, you may need to think about how do you then transfer from that syringe into the sample type used in laboratory. So there are transfer devices that are specifically designed to enable this, rather than a practice of injecting the sample through the stopper into the blood collection tube. So what's our final recommendation? Use a locking device to create a secure connection to the vascular access device. Use a blood collection tube holder, so make sure the tube is centralized, and use blood collection devices or techniques that reduce that shear stress, whether that's through a controlled aspiration or the use of partial draw tubes. And always transfer from a syringe to the laboratory sample tube with an appropriate transfer device. So what's our final recommendations? Hopefully I've been through a number of areas and we can at least come out with some initial recommendations. Collect only when it's clinically necessary. So think about the collection process and do I need to do it for this particular patient? Try to do the collection ideally on the insertion of the vascular access device, in other words, when there is no infusion therapy going, and make sure you stabilize the device before collection. Otherwise, you'll start to see some of that agitation through the movement of the catheter itself. If it's an indwelling device and infusions are going on, ensure the infusions are stopped for a minimum of 2 minutes. Disinfect the needle-free connector. That's the connector at the end of the device before you connect into it. So make sure that you disinfect that connector and allow it to dry. Flush the device with around 10 mL of saline or sodium chloride. Ensure that you have this good connection, as we said, to the device. So use a lure lock and a holder. Reduce the shear stress on the cells by thinking about using controlled aspiration and partial draw tubes. Always use a discard tube. So you need to, once you get in there, make sure that you use a discard and consider the volume of discard that you require. And then, of course, continue your collection in accordance with your recommended blood collection procedure, such as the EFLM guidelines. Once the collection is finished, flush the device with sodium chloride, and again, disinfect the needle-free connector and allow to dry. So there are a number of steps there that I rarely see in place whenever I see blood collections, and I think if we were to follow many of these steps, we would have a much improved sample quality. So I'd like to finish with a few conclusions. I'd like to go to the last question.
Again, we have one question more. Should you have a specific protocol for collecting blood samples from vascular access device? Yes? No? Please.
Whilst we don't want to influence you, we're expecting a high percentage in one answer. I think we can broadcast the results again. So I think that's great news that at the beginning we had some answers with we didn't have a process or it was not known. Now I think we all agree that there is really a need to think about carefully about how do we collect from a vascular access device. So can we obtain a high quality sample? Well, I think it's possible, but education is really required to ensure that all those involved in the blood collection process are aware of the potential impact of collecting from vascular access device. There needs to be appropriate equipment to connect to the vascular access device. It may require different equipment than that you use for your conventional blood drawer. So think about what are the right types of equipment to connect, and then of course create a specific protocol that addresses a number of the issues that we've raised during this webinar.
On the end of this presentation, I would like to add that we are in EFLM working group pre-analytic phase, defined and started with a new project, and we defined a new subgroup, catheter collection, with the aim to create awareness and initial recommendation. And so this webinar is the start point, very useful for our future work. Also, we have planned to conduct a survey of blood collection practice from a vascular access device with, as you can see here, 35 questions to enable the laboratory to audit the blood collection from vascular access device with the aim to check the compliance with the current guidelines or routine practice. Survey will be conducted across the National Society member organization, member of EFLM. After that, we will want to publicate results of that survey and finally to define and establish a recommendation. So our work in EFLM working group pre-analytic phase will continue. And we hope that in the future we will publish a recommendation about blood sampling from vascular access devices, and I hope that this webinar will help us a lot of, and Stephen experience is great for us. So Stephen, thank you very much for this wonderful, very useful and comprehensive presentation. And now we have a few minutes for some questions of participants, so I'm opening discussion. And I see that we have a question about, I don't see, question is the amount of blood to discard is the same for culture samples. The Stephen has talked about that, but can you repeat or emphasize answer this question, Stephen?
Yeah, I think again, I think the overriding comment is that if you're going to collect for a blood culture from a vascular device, don't do so. I mean, you shouldn't collect from a vascular access device unless you're doing something specifically related to trying to understand whether contamination is coming through the device or something of that nature. If, however, in a very practical environment, you have no option to do it, I don't think there's any recommendations to take a greater volume. Think about, as we've already discussed, around making sure that you have flushed the device before and taken the appropriate sample of volume of blood away from the device. So I'm not sure we can say it's a specifically different amount. I think we would say maintain the same recommendations, which, as we said, was more than 2 mLs or more than 5 mLs for a peripheral device, and greater volumes for central devices. But I think we definitely should be careful about blood cultures from a vascular access device in any stage.
Thank you, Stephen. So we have another question. What is your opinion on sampling arterial blood from catheters for blood gas analysis?
That's an interesting point. I think that routinely I would expect people to collect from what we would call an arterial line for blood collection. I think there's no, again, there are procedures and are practices that we should have in place for doing that. However, collecting from a devised catheter through a line, I think, is an appropriate way to collect a sample for blood gas analysis.
We have another question. When you detect, or with a comment, when you detect a contamination in potassium or glucose, ask for another sample, but the nurse confirms that due to the situation of the patients will not be by venipuncture, should we discard just these results or the whole results? Do you understand? You can see the question or comment, Stephen.
I'm just looking.
I don't see whole words, but
yeah. So I think what they're saying here is that they've got a sample. They know that it's contaminated, and they're then asking whether or not we should discard just those results or the whole results. I mean, my concern there would be that I think that you really don't know the extent of the dilution, and I would be very much on the cautious side of discarding the whole results. I do understand the patient's situation here, that it's difficult to obtain a sample, but I really think that if you have a truly contaminated sample that I think taking a kind of risk approach to say, well, okay, other results may be okay, I don't think is an appropriate step. And I would really be requesting an alternate sample. I don't know what you think, Zorica. Have you seen that in your experience, that a sample is contaminated? Would you release certain results from that sample?
Yes, I agree with you. I just looking to comment of other participants. Shaima Shafi, so it's not accurate results to collect blood from catheters for prothrombin time test. All of us, we know that we have in the routine practice the main problem with the coagulation tests and contamination. So
I can maybe just answer that question. So I think, again, collecting blood for your routine coagulation tests, there are many studies that show that it is an acceptable practice, providing you have a discard tube and you discard a volume of blood beforehand. So I think that's the challenge, is getting everybody to do that. I also think that when if you consider the first insertion of a catheter, you're getting a lot of platelet activation as a result of that insertion through the trauma of the insertion, and that may also impact your results. So again, it does say, let's draw a appropriate discard volume before drawing any kind of coagulation results in a peripheral catheter. I'll come back to the presentation that for a central venous catheter, I think really it's not a good idea to be collecting for